Thank you, Chairman Collins and Chairman Hendren. Thank you for your leadership. For the record, I'm Governor Asa Hutchinson, and I feel like I have the first opportunity to speak to a joint session of Congress. This is a very impressive gathering, and I first of all want to express my appreciation to the leadership. Both Senator Hendren and Representative Collins have taken time out of their schedule to go with me to meet with Secretary Burwell, as Representative Collins mentioned. And I know personally how much time they've devoted to this, but as I look out on the Legislative Task Force, I know how much each of you have devoted yourselves, both in terms of meetings and hearings, but also in terms of personal study. So in behalf of Arkansas and the Governor's Office, thank you very much. And I also want to recognize the Governor's Council on Medicaid Reform. You're integral to this process. Your ideas, your listening, your engagement in it, your communication with your partners is very important. And then we have other legislators that say, well, I'm not on the task force, but I'm vitally interested in this, and I'm grateful for your continued participation in it as well. Let me assure you that your work will make a difference for all Arkansans. Some things we do in Little Rock are important. Some things we do in Little Rock are of little significance. But what you are doing here will define our future. And so it's important what you're doing, and obviously it's important we get it right. And I talk about the future, I feel like the future is rushing upon us. We're going to have to get to the point that we're going to have to make decisions. We're going to have to define the issues. We're going to have to march forward with solutions. You have heard, and I applaud you for listening to the experts. The process you've gone through is just perfect. Information gathering, consultants, listening to the experts, expanding your knowledge base so that in the end, whenever the John Stephen Group and others make their reports, you can base good decisions upon that. So you have heard from experts, you've heard from medical care providers, you've heard from consultants. Today, I'm giving you my perspective as governor. And that is a unique perspective, it is a limited perspective, and as I make my presentation to you, I recognize that this is a legislative task force that is legislatively driven, and it's going to be a legislative solution. And I'm a different branch of government. I have high respect for the work you're doing and the solutions you're going to come up with. But I applaud you for being willing to listen to the governor and say your perspective is important, and that's what I offer today. Some of you might not know, but I majored in accounting in college. Obviously, I didn't make a career of it. But in accounting, the first thing you start with in a business is taking inventory. And I think it's important that we take an inventory as to where we are right now. In April, thanks to your leadership, legislative action, we provided stability in health care and continuity through December 31, 2016. That's what I asked you to do, that's how you responded, and we have provided that stability, and that was important to our health care providers and those that are dependent upon access to health care in this state. The result of that action and that stability has been a reduction in uncompensated care. It has resulted in increased access to health care for Arkansans. Those two facts, I think, are well established and without dispute. For hospital, the savings on uncompensated care was $149 million last year in 2014. Arkansas has substantially improved those with insurance coverage and those needing access to health care. Those are good things. Those are an excellent part of the inventory. But I also understand that there is a bill coming from the federal government, and we have to get ready. Right now, it is an accounts payable. In 2017, which is the time that we're going to have to initiate a new plan for Medicaid reform in Arkansas, in 2017, we start paying 5% of the cost of the expanded Medicaid that we have adopted. And it will grow to 10% over a period of years. And so I want to look at the numbers more carefully, and so be patient with me as we take a look at some of these numbers. The first chart, if we can put that up on the screen. This first chart is let's look, the bottom blue line that you see on the chart. The bottom blue line is our general revenues that go toward Medicaid. And what's interesting to me, just in terms of historical perspective, in 2006, when I first ran for governor, we were spending $500 million of general revenues on Medicaid. In 2014, climbs to $886 million, and then you see it escalates a little bit beyond that. And in 2017, which is the first year of our contribution to Medicaid, it goes to $1,129 million. The lighter blue line is the contribution of other tax revenues from the state. It might be the soda pop tax and other revenues that are not general revenues. And then the brown or peach colored block there, depending upon whether you're colorblind like me or not, that category is federal spending. And you can see that the federal spending has moved up to 2014 when the private option was initiated, the Medicaid expansion, and of course it accelerated at that point in terms of their contribution. The figures you ought to keep an eye on there is 2015, the federal contribution is $4.7 billion. So just keep that in mind. And then in 2017, obviously it goes up to, mine's got $5.4 billion in round numbers. And so then if you could go to the next chart. This is the projection of Medicaid spending without the Medicaid expansion. And you can see, the blue line is about the same, obviously, because it goes through 2017 in terms of the state revenue contribution. But what I want you to concentrate on is the federal spending block. As you can see, without the expanded Medicaid payments coming from the federal government, in 2015 it would have been reduced to, 3.4 million, 2017 about 3.8 million in expenditures. And the point of this is, if you look at the difference in Medicaid spending with and without the expanded private option, then you're looking at a difference of $1.4 billion to $1.7 billion into the Arkansas economy. And so if we ended the Medicaid expansion and refused to accept those federal dollars, then that is a lot of money, $1.4 to $1.7 billion being pulled out of our healthcare system in this state, whether it's to our hospital, our medical care providers, or our communities. The next chart, the third one, is probably more relevant, and this might be, well, they're all relevant. I hope that you can see this. It's a lot of information on this chart, but we will make a couple quick points on this. This reflects the impact on the state budget as a result of the Medicaid expansion dollars coming into the state. And if you look at the column that is fiscal year 15, these are the results of the private option, the Healthcare Independence Program. We had $2.5 million in administrative costs that would have come out of our state budget. We had traditional Medicaid program savings of $55 million. We had uncompensated care savings of $33 million. And then you had a premium tax revenue that was generated. And so, even though it's in parentheses, the positive impact in 2015 was $115 million as a result of the Medicaid expansion on our state budget. Now, if you skip on up through all the numbers, which are important, is in fiscal year 16, 124 million positive, 17, 94 million positive. So even in that year, when we're picking up 5% of our of the cost of the expansion, we're still receiving the benefit on program savings for uncompensated care and on the traditional Medicaid spending. The next year in 18, our benefit goes down a little bit to $43 million. In 19, we're still benefiting. We're positive numbers of $25 million because of the expansion program. And then in FY20 is when it really hits us, and those positive numbers go into a negative status of $16 million. And then in 21, it goes up to $50 million that is negative on our state budget. And then 22, 23, you can see it's between $50 to $60 million that we're in the hole. And some of you already have looked at the John Stevens report that I think it said there was a positive impact of, $336 million because of the Medicaid expansion or the private option in Arkansas, positive benefits to the state budget. That's true. As they point out, there is an accounts payable down the road we got to worry about. That's the real money. That's $50 to $6 million in our state budget that is a hole that has to be accounted for. And so we can pull that chart down, but keep that figure in mind. 2020 and beyond, $50 to $60 million, we are starting out in the hole. And so the conclusion is that if you end Medicaid expansion, you're going to be taking $1.4 to $1.7 billion out of our state budget. At the same time, we have an accounts payable coming due in 2020 and each year thereafter of about $50 to $60 million per year. And so with that background, with that inventory, with that accounts payable recitation and review, let's look at the options that we ought to be considering right now. And to me, it's a decision chart. It's a decision chart as to where we need to go as a state. Now, as you know, I opposed and continued to oppose the Affordable Care Act because of the negative impact it had on individual businesses and states. But we have to deal with the economic reality of congressional action, Supreme Court rulings, and independent executive action that expands the federal health care mission and limits flexibility. We need to deal with the reality, but push to expand the flexibility given to our states. That is an objective that I have. So coming back to our decision tree, one option that we have as a state, we have that prerogative. We can say no to Medicaid expansion. We can say we do not want to have that coverage and we want to end it. That is an option. Again, the results I've already recited is $1.4 to $1.7 billion drained out of our Arkansas economy. 220,000 will have their health care coverage ended. And I say 220,000, I'll tell you that that's the number I'm going to use because it's 250,000 on the private option at its peak. I think that it very well will result after the redetermination at about a 220,000 level. We will see, but I'm going to use that figure. And so 220,000 would have their health care coverage cut off. And we have to remember that the previous system that relied upon prior to the private option has been dismantled. Our system in Arkansas of charity care, of uncompensated care, of clinics across this state that would provide medical care to those that did not have insurance or health coverage. That system has been dismantled. To a certain extent, the uncompensated care coverage has been dismantled. Everything has changed since it was a couple of years ago prior to the private option. And we also have to remind ourselves that in addition to the $1.4 billion brought if we lose the Medicaid expansion money, we've also already lost from our hospitals the Medicare cuts that were a part of the Affordable Care Act. And that was $1.2 billion being taken out of our hospitals and our health care system. And so, do we want as a state to say no to Medicaid expansion when we're going to draw that money out of our economy, and more importantly, 220,000, there's really no reasonable plan to address their health care coverage? Now, if you conclude that we should not leave those 220,000 without a solution, If you remember in my UAMS speech, that was one of the points that I made. We're a compassionate state. We're not going to leave the 220,000 without some recourse, without some access to care. And it could have been a whole host of combinations, from the state developing its own system of care to going back to charity care. Many options, but those options have been more narrowed since that time. And so, if you conclude that we can't leave those 220,000 without some type of health care, then that brings you to another decision point. And that is, we either pay for their coverage as a state and absorb those dollars out of our state revenue budget, or we do it in partnership with the federal government. I have not talked to many that believe we can absorb the coverage for 220,000 out of state general revenues. And if you reach that conclusion that we cannot do that, then that leaves you with only one option. And that is, the federal government started this program with 100% coverage. Arkansas can't absorb that. So if we continue to provide the care for the 220,000 and access to health care, we have to have some form of Medicaid expansion with a combination of federal and state dollars. And then you have to make plans for the state share and how we're going to cover that. And so that's a little bit of a decision tree, as you can see my thought process as we look at where we need to go as a state. Now, as we consider our options, I always believe that principles should guide us. Let me cover a few principles that I think are important, a few Arkansas values that are at stake. First of all, we have to count the cost for our generation and the next. We should only assume responsibility that we can afford and that we can pay for. That's good accounting, that's good stewardship, that's what the people of Arkansas expect from us. Secondly, a value that I've always articulated, and many of you have as well, is that we must incentivize work. People who work should not look at those who don't and say, "Why am I doing this? Why am I working?" when others that are not working have more or better benefits than those that are working. People who want to move up the economic ladder should not be penalized. The third value is, I've already stated it, that the 220,000 currently on the private option should have an affordable way to access health care. In other words, we know now that those covered by our expanded health care coverage are Arkansans, are our friends, our neighbors, and our families. We care about them. That's a value that we must protect. Fourthly, when there is an option for a workable private sector solution versus a government solution, we should opt for the private sector. Now, I'm talking about Arkansas values. Maybe that's my value, but that's a principle that I want to follow. To be specific, employer-sponsored health insurance should be strengthened and not weakened by government policy. Let me restate that. Employer-sponsored health insurance should be strengthened and not weakened by government policy. I would prefer those on state-sponsored health care to shift to the employer when they get a job, and the employer policy is available and appropriate. Next, we must promote healthy behaviors and personal responsibility. That should be a part of our health care initiatives and reform efforts. Next, we need to maximize state flexibility versus a federal one-size-fits-all approach. And finally, cost savings, efficiency, and controls must be a part of any plan. These are my principles. These are the principles that I will judge and weigh our decision points down the road as to what kind of reform we need to enact in Arkansas. Now, we should pause for a moment. Some of you might be thinking this. We should pause for a moment and answer an important question. What is wrong with the status quo? What is wrong with the use of the current private option to accomplish the goals that you just recited? The answer is we can do better. The answer is that those that pushed for the private option initially said, there's going to be changes down the road. We're going to have to make adjustments. It's not perfect. Let's learn from it. It is a pilot program. As Director Seelig has mentioned a number of times, we don't know all the answers yet because it's a pilot program to see how this works. And so, clearly from my experience from from the initiation of the private option, we need to make changes, we can do it better, and we need to have a new system. There, first of all, is the future unsolved cost problem. There's no plan under our current system for the $50 to $60 million coming down the road as an account payable. We cannot hope that away. We must be prepared to pay the cost. Next, the private option does not have enough controls to incentivize work. There's not enough mechanisms in there to incentivize work. And thirdly, the current private option does not encourage employer-sponsored insurance when it is available and affordable. As many of you know, there are those that go to work. They have an employer-sponsored plan that is ACA compliant, but they don't want to pay the deductible, they don't want to pay a co-share, and so they go back and revert to the Medicaid expansion dollars to cover their health insurance. That is not the ideal, and we need to change that. So with that, let's look at the future, and let's look at some directions that we can go. First of all, let me reemphasize the point I made initially, is that you are going to determine the future of Medicaid reform in Arkansas. And I understand this is premature in some ways. You haven't got your reports yet. You've got more analysis to do, and some of that information will not come in. I think the decision time might be in October. But it is time that I offer some ideas for you to consider. Sometimes as governor you need to put some ideas out there that can be shot at, and I can be a target. So, and remember though that one of the objectives is to encourage work, is to incentivize and reward work, but also to help small employers that they will be able to offer health insurance as well. I'm going to give you 7 elements of a potential plan. Some of these are controversial, some are not controversial. And I'm going to offer these 7 elements for a potential plan to you, and I expect you to evaluate those, knock some of them off, say that's not going to work in Arkansas. I expect you to add to them, substitute to them, but I want to give you some things to think about in this presentation. And so with that, we've got a new chart up. This just outlines the points. So I'm going to go through these 7 elements one at a time. The first element of a new potential plan would be we must implement mandatory employer-sponsored insurance premium assistance. Now, let me describe that. Currently, there are many employees who have employer-sponsored insurance available that is ACA qualified. But the employee opts out of the employer-sponsored plan so they can get the coverage on the private option. Why do they do that? Because under the employer-sponsored plan, you've got a deductible, you might have a co-pay on there, you've got a premium that the employee pays. It might be modest, but it's money. And so they say, why do we want to do that when I can go on the private option and get those elements paid? And so we need to implement where they take the employer-sponsored insurance, and then we get the premium assistance so that they're made whole. The change is we would need to mandate, first of all, that when the employer insurance is available, they have to take it. And obviously it has to be ACA compliant. The premium assistance would be available for the employee to assist in the deductible and co-pays. That way, it can be comparable to what they would have if they were on the private option, but they're utilizing the employer-based policy. The premium assistance could also be made available in some creative ways to help the employer share of costs for small employers. I think that's something you might want to explore as well. The rationale for this is that this will encourage employer-based insurance to grow versus a government-only model. It will help those working Arkansans who make less than 138% of the federal poverty level to have the employer-based insurance. It will help them pay the deductible, it'll help them pay the copay. But it has to be mandated. And yes, this would require a Section 1115 waiver from the federal government to accomplish this. This is a good first element. The second element is that we need to implement premiums for individuals with incomes more than 100% of the federal poverty level. Now, currently there's no requirement in the Affordable Care Act for anyone making the federal poverty level to pay any portion of the health insurance coverage. At the same time, an employee working for the same company may be required to pay a deductible and other employee costs. That doesn't make sense to me. And so a premium requirement of up to 2% of the household income for those making above the federal poverty level may be imposed. That is a good element of a plan. And so for those below 100% of the federal poverty level, they don't have to share in the 2% cost, but as you get over the federal poverty level, it would be 2% of the income could be used for payment of premium. This is consistent with the federal marketplace, in which that's a minimum amount that would be paid by those that participate in that. The reason is, of course, that this requirement is consistent with those receiving private market coverage through the marketplace. They contribute to their plan when they're working and they're above the federal poverty level. A waiver would be required for this as well, a Section 1115 waiver. The third element of the plan is work training. Incentivize work, encourage work, push people to work, provide them the opportunity to work. And so work training referrals would be required for the unemployed or the underemployed. Currently, there is no linkage to work whatsoever under the private option. Initially, 40% that signed on to the private option were at 0% of the poverty level at the time of enrollment. There needs to be a linkage to work. Like Utah, if an individual is able, unemployed, or underemployed based upon income thresholds, then that individual will be required to be referred to the Arkansas Work Training and Employment Assistance Programs. That makes sense. It's consistent with work. It helps our people get trained. It helps them to be prepared for the workforce. This is consistent with our goal as a state of enhancing worker training, employment, and work incentives. The good news is there's not even a waiver required to accomplish this. The fourth element of the plan that I would offer to you for consideration is to eliminate non-emergency medical transportation coverage. Currently, an individual in the private option has coverage consistent with traditional Medicaid. This includes transportation assistance for medical care, including non-emergency medical trips. The change, the state would eliminate the reimbursement or coverage for non-emergency medical trips. This would save about $14.7 million. What's the rationale for this? Again, this change will discourage unnecessary medical visits and make the coverage comparable to a private sector plan. Right now, if you have a private sector insurance plan, you are not covered except for emergency trips. You're not covered for routine medical trips. And so, why should you be penalized for working? Let's have a comparable system between the two. Let's eliminate the non-emergency medical transportation coverage, and that would save almost $15 million per year. The fifth element, pay attention to this. You got bored on the first four. Pay attention to the fifth element. Limit access to the private market coverage to working individuals. This takes some explaining. Currently, under the Arkansas's waiver, the state purchases the private insurance coverage for all who make up to 138% of the federal poverty level. The change I would propose is let's restrict the private insurance coverage to a variable percent of the federal poverty level. In addition, you could add on students, those that are in work training, or others that could qualify for the private market coverage. But it would not be a system where everybody who's 0 to 138% of the federal poverty level is automatically granted access to the private insurance market. What is the reason for this? Let me back up. So what happens to the rest of them if they don't qualify for the the private insurance market? The answer is those individuals with incomes below that specific percent of the federal poverty level would be enrolled in the traditional Medicaid fee-for-service program. So they're still having full coverage, it's just under the traditional Medicaid program. This is adjustable as to what percent of the federal poverty level would be applied. It's adjustable to achieve the right balance and to maximize the cost savings. Now, what is the rationale for this? It rewards work. It places those who are working on the same ground as others who are working, and it will allow for cost reduction measures for the traditional Medicaid population. A waiver is required for this, a Section 1115 waiver. Now, let me go back over this just for a second. You have right now, on the private option, on the private insurance marketplace, everyone, 220,000 is the number I use, that's in the Medicaid expansion program. If you break that down and toggled it, if you said, well, maybe the right number is if it's 20% of the federal poverty level, you go on the insurance program, or it could be 25% that you go on the insurance program. Below that, you're on traditional Medicaid. And the goal might be, say you wanted to cap the private insurance market and access at 150,000 rather than 220,000. Then you'd have 150,000 on the private insurance market, and you would have 70,000 then in the Medicaid program. Now, what does that accomplish? That accomplishes, first of all, to be able to have more savings. I believe the final judgment will be, whenever you enact your reform proposals, that we're going to have some very cost-effective means to accomplish and to reform Medicaid. And if you reform that Medicaid side of things, then you're going to save state dollars by those that, by another, 70,000 that would be on that Medicaid roll. You might determine the numbers are different. You might say, no, we want to have more like 175,000 and fewer on the Medicaid rolls. You toggle it based upon, and it's adjustable based upon the percent of the federal poverty level. So what this accomplishes is a work incentive. It also gives those that are on the private marketplace, isn't that a great incentive? Whenever you get in the private marketplace, you're going to have greater access. Now, Medicaid has good access, and that's part of the Medicaid program, but you're going to be able to go to any fee-for-service, not fee-for-service, you're going to be able to go to any insurance reimbursable doctor that accepts whatever the insurance plan is. So it's improved access for those working. It is cost savings to the traditional Medicaid program. So take a look at that. It's a different approach to it. I think it incentivizes work. It accomplishes those values that allow us to save money, and it allows us to continue really 2 pilot programs. The 6th element is something that you're working on, and that is cost savings. My goal is to have the state revenue share of Medicaid expenditures limited to pre-private option dollars plus inflation. This means we must realize $50 million in savings per year from the current Medicaid program and the expanded program. This is 3.4% of the state contribution currently. It's manageable, we can save that money, but it's going to take some work. It is doable and it is necessary. And so if you remember one of my original charts, that if you look in 2020, whenever the accounts payable comes due, that is $50 to $60 million of recurring revenue that's going to be taken out of the state general revenue. We've got to figure out a solution for that. My solution is to accomplish that through the broad savings in the Medicaid budget. Now, the options for savings include reducing reimbursement rates, improved efficiencies overall, managed care with one or more elements of Medicaid, or expansion of the Payment Improvement Initiative. And some of you might say, I don't like those. I don't like managed care. I don't like the Payment Improvement Initiatives. I don't want to reduce the reimbursement rates. You can say no to one or more of those, but you can't say no to all of them. You've got to say yes to something. because we have to realize the savings. And so I'm asking you to accomplish $50 to $60 million in annual savings, and so that we can accomplish the Medicaid expansion to cover the 220,000 that are currently served by the private option. As part of this cost savings initiative, Arkansas should request a global waiver from the federal government, similar to a block grant approach, in which we are provided federal Medicaid dollars combined with the flexibility to manage our program, create efficiencies, work incentives, and to plow back the savings into the expanded coverage and more support for private coverage. The specifics on these savings should be based upon your work and the report of the John Stephen Group. The key is that you've got to realize those savings. The seventh element of the plan that I would suggest to you is strengthen program integrity. It is essential that those that receive the benefit qualify. The program should be audited, checked, and verified on a regular basis. As of July 1, there were over 250,000 on the private option. As I said, I expect that number through the re-verification process to be reduced to about 220,000. The cost difference for that 30,000, from 250,000 to 220,000 is $15 million per month, or $180 million per year. I believe program integrity is important. I believe that those that are on the program need to qualify based upon the income guidelines, and that is program integrity. Now, we have to balance program integrity requirements that you might impose with the administrative burden on DHS and the costs associated with compliance. I've learned some things, and that is there's administrative challenges to implement things that we do legislatively. And so please consider that regulatory burden, the administrative cost, and be practical. Those are 7 elements. I did not see anyone break out in applause on any one particular element. And that's okay. I'm putting this out there because I wanted you to hear some of my views. I wanted to put out an option and a plan that you can pick at, that you can work on, that you can noodle on, and you might have better ideas. You probably are working at those, and I applaud you for that effort. As governor, you probably understand where I'm coming from and what I've said and what I've led to in my decision tree. As governor, I will accept the continued expansion dollars from the federal government if we can achieve the 1115 waivers that are needed. These are the requirements that we need to accomplish our objectives, reinforce our values, and to afford our future. Business as usual is not acceptable. Washington, D.C. accounting does not work in Arkansas. We have to plan for the future. Now, let me make a couple other side comments to challenge you on. If you look at my initiative there, the 7 elements of that plan, none of those 7 elements require a 1332 waiver. All of those 7 elements can be enacted with Section 1115 waivers. That means that we don't have to have the sophistication of a state-run exchange. Right now, we're building a state-run exchange with a $99 million grant from the federal government. And I'm asking the question, why are we building the state exchange rather than relying upon the continued partnership with the federal exchange? And the answer that I get is, well, we need room for innovation. The innovation that I outlined are Section 1115 waivers, flexibility, innovation, work requirements, referrals, some very innovative ideas. They could be done in the federal marketplace, in the federal exchange that we are partnering with right now. So I would ask Mr. Chairman, co-chairman, to consider the direction as a task force that we need to recommend on the state exchange. If you have innovative ideas that require the state exchange, then we might need to continue to build it. But under this plan, you only need Section 1115 waivers, and it's not required to have that state exchange. Secondly, I would just offer one more thought, and that is, timing-wise, you all going to make your decisions this year. We're going to have a legislative session to adopt these changes and debate these and get that high margin of vote that we need. And then we've got to work with the federal government for the waivers that are needed, and we've got to give time for our future plan to work, so we're on a short time frame. And we're going to be negotiating with this administration. And some of you say, well, we might be able to get more flexibility in a subsequent administration. Some of you might say we're going to get less flexibility in the subsequent administration. But elections do make a difference, and so timing of when we get these waivers and when we approach those is important. We're going to do it now, but you can have a permanent solution or you can have a sunsetted solution so that we have two opportunities to seek the waivers and the flexibility that we need. But I, as governor, want to have the flexibility, maximum flexibility, so that we can run the program in Arkansas to meet Arkansas's objectives. Let me say thank you for your attention today. Thank you for giving me this opportunity to present some ideas. I've offered a specific approach. You can improve upon them, but please be politically realistic, be cost-minded, and please set aside why and how we got here. Because guess what? Why and how we got here is not necessary to the decisions to make for our future. I stand ready to work with you. Thank you for the time today. Thank you for your efforts.